here. We at Iris wake up every day and think about literally ending preventable blindness and how do we expand this program, and having a partner such as yourselves that have found a way to make it work, that are really a great example of the benefit, as you say, of offering that whole package. And it's just dynamite. So one of the things that I wanted to address is that I know that not everybody that may be on the line today or that may listen to this recording afterwards are part of an FQHC. Some folks were just interested in Iris and the program, and certainly their situation may be different. And I kind of addressed it earlier in the presentation that we really encourage all of the folks that we're speaking with about potentially coming on board with the program, to consult with your own reimbursement folks. Everybody has a different situation. Their payer mix is different. The types of contracts that they belong to are different. Their government classification is different. And so generally, what we find is that there's a number of kind of different buckets where people find, to various degrees, depending on what kind of provider you are and depending on what kind of contracts you're in. But there's really some different buckets that provide ROI. And by the way, this addresses, I believe, one of the questions that came in on the QA. Not surprisingly, two of the three that I looked at so far had to do with reimbursement. So we know that it's an important piece of the puzzle that needs to make sense in order to be able to provide this service to your patients. So anyway, so just in general, again, these may apply to different folks more or less depending on your contracts, but generally, and sometimes there's kind of an upfront, we call it a fee-for-service reimbursement, typically involves using a particular CPT code. There's a number that different CPT codes that our clients use that may apply depending on their interpretations of the codes. 92250 is one. 922227 is one. I think I used too many twos there. And 92228 is another. But again, depending on your environment, those may or may not work according to your interpretation. But typically, there's a reimbursement up front for that service. Depending on which code you use, there are technical and professional components to those codes. So we have some folks that build a global and build both. Two of those codes are only technical pieces, but we can get into those discussions individually in more detail. But one bucket is that fee-for-service reimbursement. Another area is in general quality scores being improved, and Chandra kind of mentioned this in her organization. Depending on whether you are judged by HEDIS scores or other metrics, NCQA or whatever they are. Certainly having a higher percentage of your diabetics having an annual eye exam certainly improves your metrics and improves the opportunity for whatever your arrangement is, whether it be bonuses or whether it be excess financial benefit that comes back to your practice or your clinic or your organization based on having those higher quality metrics. Obviously, that's incredibly important. Another area is an area that I mentioned before, and that is in the area of risk adjustment factor type contracts. So those contracts that reimburse based on a PM basis, and then based on the acuity of those patients, that PM number may rise or fall based on that acuity. Certainly identifying folks that are diabetic increases that PM. Identifying diabetics with eye pathology increases that PM even more. So really, it's a matter of being appropriately reimbursed for the care that you're delivering for your particular population. The last one I'll kind of talk about is the last big bucket, is really in any of those contracts where you're assuming a great amount of risk and are responsible for downstream costs. Obviously, as with almost any disease, the earlier that you can catch it, hopefully the less invasive and the less expensive that treatment will be to either keep that pathology or that disease at bay or help to improve upon it. So if we can catch folks earlier, we're avoiding those downstream costs of catching that pathology later. of them going potentially, functionally blind, that increases the cost of caring for that patient dramatically, obviously. So if we can avoid those costs, that's kind of another area where people look at in terms of reimbursement. And then the last that Chandra mentioned was in having this as a service and being able to use that as a negotiating tool can be critically important. So a number of different areas. Obviously, you may have a specific situation that would love to talk individually